Member for North Vancouver Seymour.
Thank you very much, Chair, and to everyone, welcome back. I just have some follow-up questions from yesterday, and then I'll be asking some new questions. And then I do have some colleagues that are coming in that were unable to come in yesterday because of the excitement that was occurring in the other house. So, but they're not here yet, so I'm just going to carry on. So my follow-up from yesterday, and I do have the Hansard. So the minister kindly provided this information, that there was 800,000 visits to overdose sites, 5,300 reverse overdoses, 90,000 take-home naloxone kits, and of 20,000 of those were reversing overdoses. What I would like to know from the minister is if she has a cost breakdown on those numbers.
Minister.
Thank you, Honourable Chair. So for the member asked about the cost, a couple of cost breakdowns related to the overdose crisis. So out of the $322 million over 3 years that our government invested last September, the member referred to 800,000 visits to overdose prevention sites and safe consumption sites. Now, I want to just point out that that was a number as of the end of February of 2018. So the numbers are rapidly increasing, and I would expect that when we get the numbers for the end of March and then the end of April, we will see that number is going to go up, significantly. But as I mentioned yesterday, we have committed $30 million over 3 years to the safe consumption sites and overdose prevention sites. And I do want to underline that at many of these sites, at all of these sites, there are other services that are also provided. So these figures refer to all of the services provided at all of those sites. For naloxone, the member refers to the figure that it cites the figure that I referred to yesterday about the number of kits that have been distributed, which is in the vicinity of 90,000. And she also mentions that we only know of 20,000 that have been used to reverse an overdose. But I think it's really important for the member to understand that with that many naloxone kits in circulation, they may well be being used to reverse overdoses. These are the ones we know about. So if people have them in their families, if people have them amongst circles of friends, these kits are now available. As the member knows, we've significantly expanded through a partnership with the Pharmacy Association in British Columbia. We now have over 1,000 locations where people can get the take-home naloxone kits for free. And that includes the overwhelming majority of community pharmacies where you can now get a naloxone kit for free together with a little training. So the fact that we only know that about 20,000 that have been used to reverse an overdose does not mean that there could not be I'm not going to speculate about the figures. Speculation is not a good idea when it comes to numbers, but it could be easily double that. We just don't know. It's a very good thing that there are that number of kits out there because that means that people are in a position to help to save a life. As far as the money that has been allocated, in the budget update in 27-18, we added $2 million to the program. Which is a program that is offered through PHSA. We added $2 million, so for a total of $4 million. And the same for 2018-19, an additional $2 million provided to PHSA for a total of $4 million. And for 2019-2020, an additional $2 million for a total of $4 million.
Member?
Thank you. So that was, just to confirm, so those figures were for the naloxone kits as well as the cost of the overdose prevention sites, or just the naloxone kits? I just didn't understand the breakdown.
Minister.
Well, they were two distinctly different questions, and I answered with two distinctly different answers. One answer was in response to your question about overdose prevention sites and safe consumption sites, and I repeated the answer that I gave to your identical question yesterday, which was $30 million over 3 years for all of the overdose prevention sites and safe consumption sites. And we also talked yesterday about how the number of overdose prevention sites had gone up from, I think the number was 24 and had gone up to 45. I can double check that number, but it's certainly in the blues, the transcript from yesterday. The question about naloxone kits was a completely different question. So I'm not understanding the member conflating the two questions, because they were two distinctly different issues, two distinctly different budget items, and I've given answers to both of those budget item questions.
Member?
So, okay, well then I'll just confirm this. So for the 90,000 naloxone kits that have been provided in the pharmacies, that would be encompassed in the 2 million for PHSA and the extra 2 million for PHSA in the next year. Is that correct?
Thank you, Honourable Chair. The take-home naloxone program, which is what I referenced, which is what I understand the question was about, is administered through the PHSA, the Provincial Health Services Authority. And I gave the figures for that already. In September, our government, in its budget update, doubled the number that was being allocated to the take-home naloxone program. It had been $2 million annually previously. We increased it to $4 million. That is the figure for 27-18 from our budget update, which was an additional $2 million over what the previous government had allocated. And we also doubled it for this budget year, this fiscal year, and next fiscal year. So an additional $2 million for a total of $4 million for 2018-19, and a total of $4 million for 2019-2020. The member, I think, also knows, but just in case she's not aware, people can, of course, also purchase naloxone kits individually, and many people have done that. We are making an enormous effort. In fact, we have literally doubled our efforts in order to get publicly funded naloxone kits out there, because we know that they make a difference in saving lives. And it has frankly been really, really encouraging to see all of the different groups and individuals in the community who have taken up the challenge, who are providing naloxone training. I've been so excited to know that the St. John's Ambulance, for instance, which is one of the oldest charitable organizations in the world, has integrated naloxone training and distribution of naloxone kits in all of the training they do for first aid right across the province. And we're very excited about them taking up that challenge, and so many others doing the same thing.
Member?
Thank you very much, Chair, and thank you for that clarification. Moving on the naloxone, I'm wondering if the ministry has any record of people that were revived but suffered brain damage. I have a report here from St. Paul's Hospital that they're seeing more cases of hypoxic brain injury linked to drug overdoses. And they have documented that it costs about $5,000 a day to care for someone with brain damage. But we didn't get any clarification if the ministry is tracking those numbers of those that have been revived from naloxone, but are still in hospital because of serious brain damage. Does the ministry have those numbers available?
Minister?
Thank you, Chair. Certainly, people who are working in the field of addictions and the overdose crisis are aware that there are people who have short-term, medium-term, and long-term health consequences from overdoses. And our provincial health officer, Bonnie Henry, is working with a research team of ICU clinicians in order to look at the health impacts of overdose. And that's certainly very important work that's going on. But we also know, and the member may have seen this, if not, I'm happy to forward it to her, there was a report that was out, I think it was just last week, a report that indicated that there are significant numbers of people who overdose and who are revived with naloxone who don't have to go to hospital. And that's frankly because people who are working on the front lines, whether they're working in the overdose prevention sites, safe consumption sites, whether it's people in healthcare and community agencies, or whether it's our first responders, are doing a remarkable job at reviving people and reviving people quickly. So there are more people who are not having to go to hospital than there were previously, which is both good news for those people, those individuals. It's also good news as far as the pressure on our emergency rooms. But I think the question that the member asks really underlines a couple of things. It underlines how critically important it is for us to be investing in both saving lives with naloxone and having more people trained with naloxone in order to be able to revive people more quickly. Because the sooner that people are revived, the sooner they receive care, the less likely they are to develop short, medium-term, or long-term health consequences. But it also especially points to the importance of treatment and the initiatives that we're taking to connect people to treatment as quickly as possible. Now, I say that in the context, and we spoke about this yesterday. I know the member doesn't like it when I talk about this, but the reality is we do have a treatment system that and an addiction treatment system that is inadequate. We need to strengthen that addiction treatment system all the way along the line, and that is a central commitment, central to the mandate of our ministry to do that going forward. But having said that, through the work of the Overdose Emergency Response Center, through the work of our first responders, and I mentioned this, I'll repeat it, yesterday I indicated that our first responders are now increasingly in a position themselves to connect, to be able to refer people for treatment. So not just by taking them to the emergency room, but after they revive people, we hope, and this is part of the conversation that I recounted yesterday of meetings that we've held under the auspices of the Overdose Emergency Response Center, meetings with that involved ambulance paramedics, that involve police, that involve firefighters. They are very, very eager and are already becoming engaged in not just reviving people from an overdose, but being involved in referring people to treatment. So that's good news, and it's a commitment that our government takes very seriously.
Member?
Yes, thank you for that. So how many people, if the minister could indulge me, does she have a record of the people that did actually go to treatment after being revived from a first responder that saved the person with naloxone? And then if she does have any records of how many people were sent to hospital?
Minister?
Thank you, Chair. I'm assuming that the member's questions are coming from a place of believing that it's a good thing to connect people to treatment as soon as possible, which I've indicated many times is a major objective of the work that we're doing at this stage. I will repeat what I said yesterday. I think 3 or 4 times yesterday, but let's try it a 5th time and see whether it works this time. The safe consumption sites and the overdose prevention sites, we have the figures about how many people have visited. In the case of overdose prevention sites, 800,000 visits, and at these sites, over 5,300 people have had their overdoses reversed and 0 deaths have occurred. But what I did explain several times yesterday is, and I hope that the member appreciates the reasons for this, these sites were created for a particular reason. And they were created, and I can get out the reference, but it's in Hansard from yesterday, in order to provide a safe place where people can consume drugs and where there are staff and volunteers who are able to use first aid and naloxone in order to be able to reverse an overdose, to give them the health support they need if they need it. Because of the tremendous stigma that surrounds the use of drugs and the use of illicit drugs, which the member is very familiar with, these sites do not collect identifying information. They don't collect identifying information. If they did, there would be far, far fewer people who visited them, and there would be far fewer overdoses that were reversed at these sites. And that's all about stigma. And we are very committed as a government, and I think the whole province of British Columbia knows about the work that we've done and will continue to do to try and break down the walls of silence, to overcome stigma, so that people are willing to have courageous conversations with their friends and loved ones and coworkers who they believe are using drugs, so that people are more willing to seek support and to seek help to deal with their addiction. But the reality is that stigma is still enormous, and if these sites were forced to collect identifying information, it would be a barrier, and we are trying to remove barriers in order to save lives and connect people to treatment. Part of the reason why the public health emergency was originally declared was so that at a provincial level, through the provincial health officer, that we would be able to collect data population-wide in order to really dig down, in order to have more robust data, but also to be able to analyze that data, and in order to use it to guide and to help to inform how to prevent overdoses in the future. And that work is happening, but it is at a population level. It is not overdose prevention site by overdose prevention site or safe consumption site by safe consumption site, for the reasons that I have already referred to. I do want to underline again the significant increase in the number of medical practitioners who are now offering opioid substitution therapy. The numbers as of the end of February, there was an 80% increase in the number of providers prescribing opioid substitution therapy, and those numbers will already have gone up by now, in part because nurse practitioners, 107 of 450 nurse practitioners have already either begun or completed the training, and the guidelines were revised by their college in order to be able to enable them to do that. And as we have also indicated yesterday, and this is very good news, we've seen a 164% increase in new people on opioid substitution therapy.
Member?
Thank you, Chair. I know the minister appears frustrated that I keep asking the same questions. The reason why I'm asking the same questions is because I'm not getting any answers. So I'm going to ask my question again. I know the number of visits. We have said that numerous times. What I'm trying to get to the bottom of is how much this is costing. If the ministry is not identifying people, I'm not asking for the names of people, I'm looking for the numbers. I want to get an idea of how much it is costing. And surely you must have in a budget, you surely should have the access to the numbers. The minister mentioned the term data. Well, if the public health emergency that was introduced by our government in 2016 was designed to collect more data, where is the data from 2016 to 2018? There must be some data out there that can tell us the numbers of people that are visiting these sites. And then I did ask and did not get an answer about how many people are ending up in hospital because they obviously were revived but did not get obviously help quick enough, so they've ended up in hospital with possible brain damage. And then the minister also asked or reiterated what she said yesterday, which is fine, 80% more of providers prescribing opioids substitution therapy, 28% of increase of people on opioid substitution therapy. Again, what I'm trying to get to is the cost. 164% increase of new people on opioid substitution therapy. I got that from the Hansard. So what is the cost of all of this increases? That's what I'm asking.
Sure.
Thank you, Chair. I'm not sure what the member is trying to find out that we have not already shared with her through the chair. Let me go back to something that I said yesterday. The previous government declared a public health emergency, absolutely. And a number of initiatives were taken, including the creation of safe consumption sites and overdose prevention sites through ministerial orders. However, there was a serious problem in the adequacy of the funding in order to support those programs. So health authorities were directed to do various things, correctly directed to do various things, but in many cases were asked to do it within existing budgets or off the side of their desks. When we took a look at the budgets of health authorities, when we took a look at the commitment that we'd made to escalate the response to the overdose crisis, and we heard from health authorities, they shared with us, and this is all in the Hansard yesterday, so I won't repeat the numbers, but they shared with us the enormous cost pressures they were experiencing as a result of unfunded programs, additional programs that they were being expected to provide in the overdose crisis but had not received additional funds for. So we looked at their existing cost pressures, and we looked at the new initiatives that we needed to take, and we looked at the programs that were in place that needed to be increased. And looking at all of those things, we allocated in the September budget update $322 million over 3 years, the majority of that to respond to the overdose crisis. Not all of it, but the majority of it. Now, we have already provided to the member the costs that we have allocated for the cost of the overdose prevention sites and the safe consumption sites. I could read those into the record for a fifth time if the member wishes that, but it doesn't seem to me it's the best use of anyone's time. We have already provided the costs of the naloxone program. There was some funding that had been allocated there, $2 million a year. We doubled that funding in each of the 3 years. And that's why we've been able to see a significant expansion in the distribution of and the use of the take-home naloxone kits. We have given the number of visits to safe consumption sites and overdose prevention sites. And yesterday and again today, I've reiterated that the number of OPS's, overdose prevention sites, for instance, went up from 24 to 45 since September. I've reiterated the number of visits that we've had to overdose prevention sites. Honorable Chair, if the member wants me to keep repeating the same figures I've already read into the record, I'm happy to do that, but it's really not at all clear what it is the member is trying to get at. Surely the member shares our belief, the belief of our government, and I believe the belief of the majority of people in British Columbia, that it is critically important that we have invested in both harm reduction, in saving lives, as well as moving towards building a system where we can prevent these overdoses from occurring in the first place, but in the short term and the medium term to be able to, after we save someone's life, to be able to connect them with treatment as rapidly as possible. We are working to do that. We are working overtime to do that. And again, there is literally an army of people in agencies, in healthcare facilities, first responders, volunteers on the front line who are throwing their heart and their soul into doing this every day, and we're providing the financial support to be able to do that.
Member?
Thank you, Chair. So I'm not going to dwell on this. I'm still at a loss as to what the numbers are, that if somebody is revived, how do they get into treatment? How many people have gone to treatment? What kind of treatment options? These sort of things. I was looking for numbers, but I'm obviously not going to get it. Anyways, I'm going to move on. And my question is about the nasal spray, the Narcan. I'm wondering if the minister is familiar with that version of naloxone, and if that's being made readily available, because I understand it's quicker and works faster and is simpler to use. But I'm just wondering if the minister is familiar with that version.
Thank you, Chair. In answer to the first question, yes, of course, I'm familiar with the nasal version of naloxone, of Narcan, as of course our entire team. Dr. Bonnie Henry, our Provincial Health Officer, is part of our team here today. And through the BC Centre for Disease Control, clinicians have done a review and are continuing to review the use of naloxone, of the injectable naloxone. We have had very good success. I think all of the figures that I've referred to so far indicate that we've had very good success in the province of British Columbia with the use of injectable naloxone. We have thousands of people who have used it already. The evidence, the clinical evidence, is that it is rapidly effective when it's injected into the body. And in fact, the injectable naloxone is a fraction of the cost of the nasal form of naloxone, to the tune of $75 to $3. It's also, I think, important to note that thousands of people have received training on injectable naloxone. There has been a very, very aggressive program in the province of British Columbia in training people. It is, more people are being trained all the time. That's a good thing. They're being trained on the injectable naloxone. To do the training all over again on a new form would be a challenge. We want to build on the successes that we've had. There is some evidence that from the work that's been done that the nasal naloxone, nasal Narcan, is not as effective in some cases. But again, this work is continually being reviewed. But the evidence so far is that we've had very good success with the injectable naloxone and that it is a very cost-effective means of saving lives.
Member?
Thank you, Chair. Just to follow up on that, my understanding is that, again, we canvassed this fact yesterday, that given that the majority of people that are dying alone and home are the general public. In other words, they don't have access to first responders in that they would have at an overdose prevention site, that it would seem that it would be easier to have a nasal variety available for the general public, as opposed to having to train the general public, which of course the general public is not getting trained. It's the first responders and the people that are in the business that do. So my question is wouldn't it be simpler for the general public to get access to the nasal version so that they could get the drug into the person's system quickly and more efficiently without having to be trained?
Through the chair, with the greatest respect, perhaps you could share the question first and then we would know.
Member.
Thank you, Chair. It's about, it's actually a mental health and addictions facility who had requested licensing and were rejected for some reasons that I've got here. And I had some questions as to what the criteria of what evidence-based individualized programs, which is one of the reasons why they were rejected. My question is, what is evidence-based individual programs, and if she could explain what that is, because this facility did not get an explanation on that.
Minister.
Thank you. That would be a question better directed to the Ministry of Health.
Member.
Thank you. So I have just a few more questions. I think we're going to wrap up probably in the next 15, 20 minutes. And one of the questions was, does the minister or the ministry have any stats on overdoses with methadone?
Minister.
Thank you, Chair. Let me say first that there have been no deaths where Suboxone has been detected, which is very important, and Suboxone is the first line of treatment for opioid use disorder. There have been some deaths with methadone where people are found to have had methadone in their in their system, but the coroners are unable to determine what caused those deaths in most of the cases, because often when methadone is found, it is also found in combination with other drugs and or alcohol in people's systems. So in so many of these cases, it's impossible for the coroner to determine, did the person use too much methadone, or did they, more often than not, they can have methadone in their system, but they could also have other drugs in their system, alcohol in their system, fentanyl and carfentanil in their system. So is it the combination of various different drugs? That's a coroner is able to say what was found in their blood, what was found in their system after they died. It's far more difficult to identify if methadone is one of the things in their system. Is that what led to their death?
Member.
Thank you for that. Then I have a question that a constituent asked me to ask the minister. Is there any plans or any recovery facilities that focus on non-substance use addictions like gambling, food, or pornography?
Minister.
Thank you. The member referred to, or maybe her constituent referred to, facilities. I'm going to refer to facilities and programs. So we already have programs in place, both outpatient but also in facilities for eating disorders. Children's Hospital is one of them. There are other programs for eating disorders. We can certainly get that information to the member. Gambling is handled under the Ministry of the Attorney General, so I don't have the specifics on that. I do know that there was just recently an increase in funding for that gambling addiction program. And for, I don't know about addiction to pornography specifically, but for sex addiction services, we don't provide any of those services in British Columbia. They are provided in Ontario, and I'm told that we do pay for people to access those services in Ontario.
Member.
Thank you, Chair, and thank you for that answer. I have another question. The Minister has been very committed to doing everything that we can to stop the stigma around mental illness, and I support her efforts on that. Certainly, I've been an advocate for trying to stop stigma as well. So my question is to do with a group called Stigma Free Zone, which is run by Andrea Pouquet. And her question to me, to the minister, was, is the ministry, and maybe again this is a message to the health ministry, but I thought considering we're talking about mental health and addiction stigma, that it would be directed to this minister. Will her funding for the work that she does in schools and in other areas be reinstated at some point this year?
Minister.
Thank you. Well, I'm not sure. I'm not sure where the funding has come from for this organization, Stigma Free Zone, and which funding decisions have been made. I'm certainly happy to look into that. You mentioned education, so I don't know if it came from education or where. Well, certainly, or whether it's health authority, and if there's a decision by the health authority, we're certainly prepared to look into that. And certainly we have a very broad commitment to expanding our anti-stigma work. The work that we've done to date in partnership with the Canucks has, we think, generated considerable interest and support across the province. And we've had people express that it actually has opened their minds, which is exactly what we're trying to do. So I don't know the specifics in this case, but we will look into it.
Member.
Thank you, Chair, and I would be happy to pass on this information to the minister. It's a great program. I've seen it in action, and she's a dynamic speaker. So, and she's got a staff now. She's grown. It's not just her. So my last couple of questions, and then my colleague has one that she forgot to ask, and then we will be done. My last two questions are to do with students. And I'm sure that the minister, like other MLAs here, has been visited by student associations, AMS, UVSS, Alliance of BC Students, Simon Fraser Student Society, etc. And I really liked their recommendations, and this is the Medical Student and Alumni Center, Undergraduate Society. But they did have some specific asks to do with mental health, and specifically post-secondary students. I had talked about my desire to expand Foundries to post-secondary institutions province-wide, which of course this group is very supportive of. But they wanted to know whether or not the ministry was willing to do any research on suicide prevalence amongst this age group, because suicide and suicide ideation is becoming an increased concern at university campuses. So specifically, they had asked for the minister if there was any interest in evaluating suicide prevention and getting the data that we need to target this particular age group in universities.